Our next speaker is someone that I have known for many years. When I used to work at the Royal Berkshire Hospital. And then he's lead for pain management. And, you know, Deepak Ravindran, well, has been very passionate about showing how, you know, community is so important. You know, he believes that community has a vital role to play dealing with isolation and especially now with the lockdown related issues. Just to make you aware, Deepak has been involved in West Berkshire in a big way, in a project where he's been dealing with the hidden disability called fibromyalgia and how it affects the youth. And that project was piloted in West Berkshire, and hopefully it will roll through to other places. Deepak, the floor is yours.
Excellent there. Now, I just have a small presentation to show. Thank you so much, Carol, Alice, and Julian for making this happen, for bringing through Community United. And I think it's a fantastic venture that should really be what should be the model of what a community needs right now. And I hope that in the next 8 to 9 minutes, some of what I tell you is going to be surprising, but at the same time, I hope it will provoke some thought, some really careful introspection into how we should be looking at building up community. Now, I'm a lead for pain medicine. I help all the GPs and the pharmacists in the entire West Berkshire as well as Berkshire area in terms of guidelines for pain management. And I look after patients who are admitted in hospital with pain and who are in the community with pain. And you might ask me, well, what's my role and why am I doing this in the community side? And I believe that it's massively important that we understand what aspects of pain is going to be influenced by the kind of stress that we are going through, the unprecedented stress that we are going through as a nation and as a community right now. And as Mark said, you know, the distinction sometimes between religion and state there, the distinction between mind and body as well, which we've all grown up to believe in, is equally a false dichotomy, which causes its own pain. So is it all right if I kind of share my screen and the presentation, Alice? Is that okay?
Yeah, go ahead.
Do I have the power to do that? Because I think the host has disabled my screen sharing apparently. Or if you have my presentation, you can do it as well.
We should be good to go now.
We should be good to go then. Okay. Hold on. Let me see whether I can do that. Brilliant. Okay. So there I have. Let me know if all of you can see that.
Yes.
Can you see that there? Okay, brilliant. Okay, hopefully going to take it to full screen if that's okay. Excellent. So that's my title really, and that's where I'm going to focus on the connection between social isolation and pain, the connection between what we think of pain as a body phenomenon to something that's beyond that, and where befriending really makes a role, and what organizations like Community United and its timing of setting up is so important and useful. So we have all talked about and we've understood how ethnic minorities have been so hard hit with the coronavirus. I myself, I'm a COVID survivor. I had a horrible 8 days at home, really, recovering from it. Of course, my recovery was not reported in the same time because Boris Johnson hogged the limelight. But I have to agree that these data that came out, the theme that came out constantly as to why the BAME community suffered so much more is that there was an element of systemic racism. There was deprivation as a common factor. There was inequality that was visible for all to see. But there was also the comment that came from certain other articles that household size, which was a feature and which can be related sometimes to the cultural context. And in fact, also this came out that how the message of looking after yourself, looking after others, looking after your family was not delivered and disseminated equally and effectively to ethnic minorities. The penetration was an issue there. And the data is visible on how much of the death was occurring in these patient groups, to the extent that there were big articles and guidances that came out like this about being hidden in plain sight. This is all in the public domain for you to access and read about if you are interested. But it makes more difference, because from my perspective, when you look at that, to me, it went one step deeper, because there was also the evidence that was coming out in the literature around pain, that there was a potential increase for chronic pain after this pandemic. I mean, we haven't even gone past the first wave and we're being threatened by the second wave, but there was already data coming out, and from previous epidemics that had happened in Canada or Singapore after the SARS epidemic, that patients can have infections, viral infections that can trigger chronic pain. The COVID-19, and for those who have had severe forms, they might have had ICU stay that can leave them with chronic pain and fatigue. Pre-existing pain can be made much worse because of isolation-related issues and not having care quick enough or proper enough. You might have new problems coming through. And we realize that there's a group of patients who have had moderate COVID, who haven't needed hospital care, who are now coming through the system with pain and fatigue that is lasting long after they should have recovered from having a coronavirus infection, but it is not going. But the biggest focus, and for me that was most interesting, is this constituent of social determinants of health. When there is inequality, when there is deprivation, when there is chronic stress, that brings on its own kind of chronic pain. That means that there is a relation between how the mind is responding to these things and how the body is then bringing out those phenomena. Very important to think about that. We don't sometimes think about it. We think pain always has a structural focus. It must be coming from some part of the body, you know, the knee or the back or the throat or the neck, but it doesn't have to be that way. And when you dig deeper, I realized that actually in chronic pain as well, the perception, sometimes cultural context of what we think of pain, you know, can make a difference in how we perceive pain. That concept of how we think about why pain is occurring to us may have a religious context, may have a cultural belief that comes from how our parents and our community thinks of pain. And that changes from culture to culture. How an Afro-American may think of pain may be very different from how an Asian might think about pain, or how a Caucasian may think about pain. And all of that needs to be factored in when we approach pain management in a community, and that plays its role in the hospital as well. Take, for example, the study. This was something that just blew my mind when I heard about it and I read about it in 2012. But this was a study wherein they looked at what happens with social isolation. The experiment was exquisitely simple. They had participants who were taking part in a computer game. So you had two computer players throwing the ball at each other. The experiment involved a participant being introduced as the third player in the game. So this game was called Cyberball. And at the same time, this participant was being scanned in a functional MRI. This is a research kind of MRI scan wherein you can see which parts of the brain light up when you do certain activities, or when you feel pain, or when you feel other emotions like anger or sorrow or despair or hope or joy. And when they did this experiment, the first part of it was the ball being transferred from the computer player to the real player, and the real player pressing a button and it goes to the computer player. After about 15 minutes of doing this, the game changes where the computer players then pass the ball to each other and exclude the real participant. And what they noticed was that the same areas of the brain lit up in the real participant when they were felt excluded, when they were felt isolated, when they were felt stigmatized or ostracized. And these areas are exactly the same areas that light up when you feel physical pain, when somebody pinched you, when somebody hurt you, when you had an injury or surgery. The areas of brain that lit up are the exact same areas that light up when you're isolated, when you're ostracized, when you're marginalized. And that is very important to understand, that at a neuroscientific level, we're realizing that the chemicals released are the same. And if you then take it one step further, if you talk about addiction-related studies, the rat park, and I'll go into it later if there's time out there. But these studies have shown that addiction is often a problem that occurs when there is social isolation. When people have these problems of not connecting well, that's when the risk of dependence on other, it doesn't have to be just drugs. It can be internet, it can be porn, it can be shopping therapy, it can be sugar, it can be any other form of dependence. Doesn't have to be just drugs alone that we think of, or opioids, but it can be other things as well. And you can all check out this particular YouTube, a TED talk that was done by Johann Hari, where he talks about how he looks at addiction and why everything that you understand about dependence and addiction has to be had a rethink. And it has gained 16 million views up to now in 4.5 years of being out there. And he says that the opposite of addiction is connection, is bringing about community. And I would say that this is what we need to do as a community. Some of the way, the vision that Community United has talked about is to look at this data collection around ethnicity, to understand the impact, not just of COVID, but of any other disease that comes through among the BAME groups, among ethnic minorities, and generally in the community, is to look at improving the access, look at how we can get culturally congruent and appropriate tools for each community, whether that's in occupational health, whether that's in health promotion, whether that's in disease prevention, whether in just COVID-19 education, pain education and prevention at a grassroots level. All of this takes into account in how we reduce inequalities due to social determinants of health. And this can be done by good quality research that comes from the community, from the grassroots. And I'll end by looking at this. This is a very influential book for me, brought out by an economist at the International Monetary Fund about last year, where he argues that we've taken in the last 40 years, we've galloped so far forward with encouraging the market and being capitalistic, and the government has thought that capitalism and market can sort everything out. You've left the community behind. So actually resurrecting the community and bringing the community back through this concept of what's called inclusive localism, looking after the big T, you know, the big traumas, the big abuse, the neglect, the emotional neglect, the physical abuse, the deprivation that comes along, and the small T's, the bullying in the workplace, the harassment that someone goes through, relationship difficulties, separation, divorce, loss of a job, furlough to redundancy. All of this makes a difference, because the next generation of care that has to be provided in the community and in the hospital has to be something that I call trauma-informed care. Understand the traumas that go after a person, because all of that influences their pain experience, their pain response, and tackle the isolation that comes through. Thank you.
Thank you. Thank you, Deepak. I mean, this is very interesting. It's the importance of bringing the community together, and I think this is vital, because I think if we ask the community what they want, I think we achieve far more things, to be honest. So thank you very, very much.